Dr. Baliga here. I have another terrific podcast for you, the Must Know EKG podcast. You'll find this podcast educational, like all other podcasts in this Must Know EKG series. This podcast is derived from EKGs available at mastermedfacts.com. A 58-year-old male with sleep apnea is seen by his PCP who does a routine EKG, and it shows this EKG. This EKG shows A. left ventricular hypertrophy, B. left axis deviation, C. right ventricular hypertrophy, D. left bundle branch block, and E. biventricular hypertrophy. These are the choices. And the answer is choice 3, right ventricular hypertrophy. There are numerous criteria for right ventricular hypertrophy, and these include right axis deviation of 110 degrees or more, a dominant R wave in lead V1, which is greater than 7 millimeters tall, or an RS ratio greater than 1, a dominant S wave in V5 or V6, which is greater than 7 millimeters deep, or an RS ratio less than 1, and a QRS duration is prolonged but less than 120 milliseconds. That is, these changes are not due to right bundle branch block. Supporting criteria include 1. Right atrial enlargement or P pulmonale, right ventricular strain pattern, that is ST depression and T wave inversion in right precordial and inferior leads, an S1, S2, S3 pattern, that is far right axis deviation with dominant S waves in leads 1, 2, and 3, and deep S waves in lateral leads, that is 1 AVL, V5, V6. Accompanying features include right bundle branch block. It's really important to know the sensitivity of EKG criteria for RVH is generally low. Some criteria have high specificity and can be used to advantage in diagnostic schemes or to derive continuous variables. The greatest accuracy is in congenital heart disease, with intermediate accuracy in acquired heart disease and primary pulmonary hypertension in adults. These are some of the criteria for right ventricular hypertrophy. Prominent R waves in the early anterior precordial lead and prominent S waves in the lateral precordial lead suggest increased myocardial mass of the anteromedially situated right ventricle. Additionally, associated findings help to distinguish RVH from other causes of right axis deviation, or prominent R waves in lead V1 include R wave in V1 greater or equal to 7 millimeters, an RS ratio in chest lead V1 greater than 1, an RS ratio in V5 or V6 less or equal to 1, if an RSR prime pattern present with an R prime greater than 10 millimeters, a QR complex in lead V1, that is small q large r, and an R wave in V1 and an S wave in V5 V6 together are greater than 10.5 millimeters. Associated findings help to distinguish RVH from other causes of right axis deviation, and these include right atrial enlargement, incomplete right bundle branch block, or an RSR prime in lead V1, and persistent precordial S waves. This concludes this Must Know EKG podcast. Follow me on Twitter at RRBaliga MD.